My name's David Wortley. I'm the CEO and founder of 360 in 360 Digimed TV channel, and I'd like to share with you my vision for Digimed TV. We're living in a world now where coronavirus has really changed enormously the way in which we live. But with that change has come an opportunity to build a better world, a world which is more sustainable in every aspect, whether it's the environment or in particular with health. Coronavirus has highlighted the fact that lifestyle related conditions are placing a huge burden on our public health services and making them unsustainable. We've managed to control the situation to a large extent through the use of vaccines, but it still raises the problem that many of us are at risk of poor health and at risk of getting the coronavirus because of our lifestyle related conditions like obesity and diabetes, etc. They make it more likely to get ill, and they make it more likely that when we do get ill, we will die. So one of the main objectives of Digimed TV is to create a platform to share ideas on how we can better manage health through digital technologies. Thank you. Welcome to this afternoon session of Digimed TV focusing on preventative healthcare. We have some absolutely fabulous guests this afternoon, all of whom have got expertise in preventative healthcare in different sectors. So I'm going to start straight away by inviting Leon Eisen into the studio. Leon, where are you at the moment?
David, great to see you again today. I'm in Israel now.
Okay.
Very good weather, sunny.
Well, we have good weather here too in the UK. Fortunately, it's a little bit warmer today, so it's all very, very welcome. Before we actually go into looking at some of the technology you're involved in, could you give us a bit of an update in how Israel is handling the coronavirus situation? We understand in the UK that they're doing very well.
Currently, we are doing very well, and it's dropped down almost. We don't have new cases, very small number of new cases, and about more than half of population is vaccinated, even more than half of population. So actually, we have immunity, and I don't see any problem today. And our government, step by step, easy all these. Everything is open now.
Good. Well, we'll move on to the topic in question and the use of digital technologies for better managing your health. Can you just say a little bit about the situation with long COVID and the kind of characteristics that technology needs to have to be able to look after patients with long COVID?
Yeah, right. Very good question, because as we know, and last in the research just proved that about 30% of COVID patients experience some complications, post-COVID complications. And these complications include heart diseases, lung diseases, respiratory diseases, kidney diseases. So all spectrum of diseases could be complications of COVID-19. So it's required some very specific technology that enables to screen these complications before these complications became dramatic complication and dramatic disease, more dramatic disease. And to stop these complications to develop into adverse events, it's very important to give patients some capabilities how to screen their disease for a week, for example, and how to manage some models to prevent these diseases, and most important, to diagnose and to prevent these diseases. So we can do it through the models, specific models of pattern recognition, patient multi-parameter management, and patient care coordination.
So there is a lot of technology that goes on behind the scenes, and a lot of people like myself are users of devices like Fitbit, and we use these devices to manage our own personal health. Perhaps you could just explain a little bit for those people who are not that familiar with the marketplace for wearable technologies, the main differences between devices like Fitbit and consumer devices, fitness trackers, etc. What are the main differences between what your proposition is and these types of devices?
I'm happy to see that you are adept of fitness trackers, and you are happy, and we're happy not to use devices like Oxytone, for example, because there is a huge difference between wellness devices like Fitbit and medical devices like Oxytone, any Holter, or blood pressure monitors. So the main difference is that wellness devices are dedicated for patient behavioral change. I want to make sport, I want to prevent some maybe upcoming diseases, I want to prevent flu or identify some flu. I take wellness device, I can answer some questionnaire, and in this case, I can get very superficial care coordination and some behavioral health behavior change. In the case, if patients has already very complicated disease, we call it complex chronic diseases, wellness devices is not enough, because you need medical grade data. You need to catch up with event. You have to measure blood oxygen saturation, you have to measure blood pressure, you have to measure respiration rate on the hospital grade level. And you have to do it every second, not to lose some event. Because if you lose event, you can land into the hospital finally, or emergency room. And wellness cannot help you to do it. It just could tell you something, some picture that, okay, maybe deterioration could happen, but it doesn't give you a full picture of patient's health status. I'm talking about complex chronic disease patients. And this is the most important difference. So wellness devices for wellness applications, and maybe for some initial disease application, just to understand the stage of disease. And medical devices, wearable medical devices, specifically dedicated for high-risk patients, for example, patients with conjunctive heart failure, level 3-4, patients with COPD, level 3-4, and these enable to predict complications, to follow patient after discharge, to reduce readmission.
Yeah, I guess the way I would think of it, and probably try to explain it, is that if you were admitted into hospital, you wouldn't be very comfortable about the doctors and nurses just using the data from your Fitbit as a way of determining how well you're
They're not comfortable.
doing.
Doctors not comfortable using this data. We don't care. Doctors care.
Yeah, so the devices like Fit and many others, and there are some fabulous devices and applications for personal health management, encouraging activity, good sleep patterns, dehydration as well. All of these things are, I find, excellent with Fitbit. But I guess if I was in a situation where I needed real-time care like you would have in a hospital, then it's better to have devices like Oxytone and similar devices.
Right, exactly. This is the issue. So you cannot find Fitbit or Apple in the hospital. Yeah, you will never find it there. But you will find medical devices, and today even Oxytone is accepted by some hospitals for measurement of patients, and patient could just get around the hospital and still be connected in real time, and if something happens, could have some help. Same at home. For example, one of our value proposition in Oxytone, for example, we offer screening or weekly screening of a patient post-COVID-19. So for the week, we can gather a lot of data multi-channel, multi-parameter data, about 7 channels of medical grade data. Then we have the pattern, we can build the pattern, we can build the model, and we can tell exactly a physician, and they could generate report about what happened to patients. We can tell physician exactly what happens, what kind of event patient could have or had. And physician could identify this event and identify correlation between multi-parameter patterns and decide about care plan of these patients in real time.
Yeah, well, I thank you again, Leon, for joining me this afternoon. We've now been joined by in the studio by John Warner. So I'm going to bring him into the stream just so that you can see each other to begin with.
Hi, John.
And I just thank you. I thank you at this time for joining us this afternoon. Please hang around for the rest of the programme and meet some of the other guests. I think they'll also be of interest into particularly Pete Stevenson later on. I think you've got some interesting things in common with potential for collaboration. So I'm now going to concentrate on John, and I'm going to ask John, first of all, to tell us a little bit about himself. And his background and his involvement in this topic area.
Very good. Well, thanks for inviting me, David. I've been in and around healthcare for more than 25 years now. I actually had some time, as you can hear from my accent, in the UK, working with the National Health Service for a little while, worked in the Australian healthcare system. But I've been out in California for 17 years now. I'm working in the American healthcare system. Most of my work is with startup companies and early stage companies in the digital health sphere, helping them at the strategy level and in becoming investable, so they've got the capital to grow. My particular passion is in the older adult community as a target customer. I don't think we have enough entrepreneurship in that space, and we don't understand the end customer well enough. So I tend to focus on the population of 50 years of age and older and their particular needs across the health spectrum, whether that's on the wellness side or on the curative side in terms of their health needs. So that's a quick summary.
Well, that's splendid, because I certainly fall into that category, as you can see by the colour of my hair, which raises an interesting question, and that is the impact of COVID-19 on the health sector. Now, clearly from everything that we know about COVID-19, older people and people with pre-existing conditions are particularly at risk. Perhaps you could just share with us some ideas of the way in which digital technologies could help to protect that kind of cohort of the population.
Yes, it's been devastating, of course, for the older adult population, and particularly those with chronic conditions. I think we often put sort of old and frail together with preconditions, and I think preconditions are the dominant issue. And in some cases, people don't seem to be aware of where they're at risk, and I think that's where we've got a wonderful opportunity to educate people just in time via their devices in terms of where they're at risk and where they should take extra care, whether it's simple steps like hand washing and mask wearing, or whether it's things they can do from a health perspective. And if you think about not just COVID-19, but potentially future epidemics and pandemics, I think we have to get this right for the future. And I think digital health can really help in a number of ways. And I think it's going to be something that's helpful to all vulnerable populations. I think the one I'm interested in is older adults, but I think it's true in general. We've seen many groups have issues with COVID-19 and being unaware of why they're at greater risk. So I think that's where digital health can really make a massive difference in showing them their risk profile and the steps they need to take in terms of being better prepared.
So one of the big problems, I think, with health, or certainly in my experience, is that there is a time lag between bad behaviour and you suffering the health consequences.
Yeah.
And as I spoke this morning about Sir Simon Stevens several years ago, saying that lifestyle-related conditions like obesity were really a car crash waiting to happen. So how do you persuade older people to take more interested in lifestyle behaviours? Are there any kind of generic solutions that you can think of that would act as a kind of incentive to help older people to better manage their health?
Yeah, I think it's almost the reverse, David, of that. I think the first thing you've got to do is understand them. I think one of my pet peeves is that we tend to be pejorative about older adults. We tend to go and think about them as one monolithic whole. You know, we use terms like seniors or boomers. I just use 50 plus. That's 120 million people in the US, for example. That's a giant population of people with all sorts of nuanced needs in between. And guess what? They're all motivated in completely different ways, just like the younger population would be. Now, I'm a psychologist by background and training, so I'm very interested in the whole field of behavioral economics and nudge theory. But I think it only works when you've actually thought about the end customer and their needs. So if we're going to talk about older adults, I think we've got to understand who are they, both demographically, so there's all sorts of curves that run through the population, age being one of them, but then psychographically. So we really understand what motivates me is not necessarily what motivates you. So I think we're all gamifiable, to use that sort of horrible term, but I think it's in different ways. In some cases, I think you can do it simply and activate the lizard brain, you know, by getting people to do things that are good for them. In other cases, we have to be more sophisticated. But I think we've got the tools in digital health to do that now, to both understand that customer and then design the nudge theory so that it fits that end person's wants and needs psychologically.
Yeah, I agree with you entirely. Having been involved in gamification for quite a number of years, starting with the Serious Games Institute many years ago, I certainly concur with you that gamification is very personal to the individual, and what works for one doesn't work for another. Can I just ask you a little bit about the differences that you've experienced with the healthcare systems in different countries? As you've got a lot of experience from the UK, you spent time in Australia, you're now in the USA, and can you sort of reflect on the differences between the healthcare systems for individual citizens in these countries? How are they different, and what's the effect of those differences in the current coronavirus climate?
What a question, David. So
Yes,
we had about 14 hours to talk about this. So let me be sort of relatively simple about Australia versus the UK. They're similar systems. They tend to be a sort of single payer, single provider system. A lot of parallels. I think Australia takes its older adult citizen a little bit more seriously than the UK does, but there are broad similarities in the way the system runs and it's funded. I think obviously the big difference is the American system, which is founded on completely different principles. It's different in the public sector and it's very different in the private sector. And then, of course, I think you have to add the layer of complexity that comes with having a federal system, but then a system that not only becomes 50 states, so which makes it kind of bigger than Europe in terms of its sheer size and scale, but all of its policies, procedures, reimbursement mechanisms, etc. But a lot of that money is devolved down to county level. So if you imagine that in a UK context, it's like sort of getting down into individual cities or, you know, sub-county level. And having money parceled up that way. And that makes for a horrible complexity. And I think when it comes to things like the vaccine, one of the problems with the rollout is coordination. How do you coordinate across a federal system, a state system, and then a county system is big? California has more than 50 counties, for example, the state that I'm in. That's a huge coordination effort. Lastly, obviously, the reimbursement side is hugely different. We've been in a fee-for-service system for many years. We're trying to transition it to a value-based system. That's a very heavy lift, and it's going extremely slowly. And I think that leads to an enormous amount of waste in the US system, which we're trying to tackle, but it's not an easy task.
Yeah, I noticed from some of the statistics, particularly for the elderly, the USA has really quite a staggering difference in the cost of elderly care compared to many other countries.
Yes, they sure do. And I think that there's one thing that I think perhaps your audience might be interested in, though, and that's that I think one of the things we don't do is look at social service side costs and healthcare costs at the same time. Yes, the US spends a lot on healthcare, more than the rest of the world, double the OECD average, for example. But it actually doesn't spend very much on social services. And when you combine them, it's actually in the middle of the pack. So you might argue that if we were spending more time on social determinants of health, access, equity, transportation, and so on, and even social side care, I think we might see those healthcare costs go down. And I think that's a debate that's raging right now in this country. But I'd encourage people to look at both of those numbers at the same time. It's surprising how level the US is with the rest of the world when you combine the two.
Well, thanks for those comments. We've been joined now by both Pete Stevenson, who's my next guest, and Noah Folstein. I can see them on my screen now. So I'm going to bring Pete Stevenson into the room, and just thank you for your time, John. Please hang around, because if you've got time this afternoon, we can have a bit of a panel discussion right at the end after we've spoken to Noah. So I'm going to bid you farewell for a few minutes and now invite Pete Stevenson, who's the president and COO of eCare 21. Pete, to begin with, just tell us a little bit about your background and about eCare 21.
Sure. I've been in the technology space for over 40 years, going back to Bell Labs. And then I had a company in network and security event management, sold that to an audit and compliance company. And that rolled up into IBM, where I ran their worldwide security SWAT team. Over the last 4 years, I've been with eCare 21. I left IBM for this because it was a vision that I just couldn't refuse trying to achieve. eCare 21 has emerged as one of the leading players in virtual care and providing an ecosystem for a patient-centered virtual care platform. It combines telehealth, remote patient monitoring, and chronic care management for a unified software as a service solution, mainly focused today on post-acute care for seniors, for the aging population. And our mobile app has been recognized 4 years in a row as one of the best apps for caregiving. And we've integrated that in a complete solution, and it's starting to really pick up now.
Well, that ties in very nicely with the conversation I just had with John, because he's particularly interested in the over 50 side of the population, and I know that Leon Eisen would be very interested in your work, because he has the Oxytone medical grade wearable device, which I think could integrate in terms of providing data for eCare 21. Unfortunately, we don't have a lot of time in these fireside chats to explore things fully, but in our conversation last night, you mentioned a patch device that you are wearing. Would you like just to say a little bit about that and explain what it is and how it works?
Sure, absolutely. And one of the things you're seeing in the device industry right now is they're moving into smaller devices. Many thanks to Elon Musk and battery technology, batteries are getting stronger and smaller. And as a result, they're now, the whole industry is now able to shape around very thin and simple devices like this one I'm going to hold up here. This is a BioIntelliSense Bio Button, and this is a BioIntelliSense Bio Sticker. And these are very, very simple devices that integrate with our platform. And you essentially take them and you stick them on your chest about 2 inches below the breastbone, and they emit data in real time on things like breathing, oxygen, movement, gait, coughing, wheezing, say if you have got a cancer patient. And eventually they're going to have other things built into these smaller devices. that will allow you to monitor the patient's vitals, physiological vitals, with a simple patch. And this combines the things that are coming in, say, an Apple Watch. I have an Apple Watch. It has an ECG. It has your pulse ox. It has heart rate. And it rolls up into our platform in real time. It's really fascinating in this space right now because you can now trigger alerts on out-of-range conditions. So not only your physician can be aware of those out of range, or your nurse, the people who are caring for you in your circle of care can also be aware of it as well. It's quite fascinating what you can do when you blend technology within the clinical and workflow of your personal network, which is caring for you on the ground.
So in the conversation that I've just had with Leon, we were talking about medical grade devices and the difference between devices like Fitbit, for example. And I've noticed in the Sunday newspapers in the UK, there are some ridiculously priced wearable devices that claim to measure blood pressure and oxygen saturation, a whole host of other things. So where does your platform and your ecosystem, what are the primary targets for your solution? Are you aiming to get traction from the general public, or are you primarily targeting at the medical sector?
So initially, we grew up in supporting primary care physicians, and then we moved into specialty practices, with cardiology being a big focus now. Cardiologists are dealing with one of the biggest issues is heart health. And we're also moving into the home care space and subacute care, where skilled nursing homes discharge their patients and the patient's data goes dark. In most of these electronic health records, once you're discharged, the patient goes home and the clinicians don't have any visibility to what's going on. What eCare 21 does is bridge that data divide, so your data, you own it, you control it, and it follows you everywhere you go across the care continuum. So one business model that's shaping right now is you're finding these subacute care environments discharging patients and finding that our platform actually is a super EHR, in a sense, is that we can make the data visible between settings of care, and it allows them to form a bit of outreach to reduce risk, which reduces their cost, because now they're taking care of patients virtually, remotely, and it also gives them a bond to the patient that they haven't had before. They have a relationship, and they can engage with the patient's caregivers, and encourage the caregivers even to pay more attention to certain things that are important, because that data is shared within their circle of care. So it's, again, a quite fascinating space that's emerging right now, but we seem to be in a good spot.
Yeah, I think the digital health care ecosystems are certainly the way to go. And I think particularly when they can embrace all the stakeholders in health. So could you just say a few words about the business model? Who will be funding eCare 21? What will the patients, what will the carers pay? What will the healthcare systems pay? Where is the revenue going to come from?
So initially, again, we focused on subacute care and post-acute care for seniors. Medicare eligible was a target population, dual eligible. So those patients 65 and over immediately qualify for a device to monitor them at home. And there is reimbursement underneath the CMS policy for remote physiological monitoring using a connected device. So you can, as a provider, deploy a device to a patient, train them on that device, say in the facility, which is one model in the skilled nursing facility, and then discharge the patient with that device and follow up. And there's reimbursement for the training and education on the device. So a clinician or a medical assistant could construct the device, make sure the patient is using it properly. And then when discharge occurs, a nurse is typically following up periodically. The reimbursement is available if you follow up within 48 hours, for instance, for transition care management. develop a care plan to remotely follow the patient. There's hundreds of dollars there, a couple $100 in that pot. And then there's reimbursement for the device itself once it's deployed in the home, and there's certain criteria you meet, like 16 days reporting out of a 30-day window. There's $69 per patient per month available for reimbursement, which our platform documents and will generate a clean, compliant bill. So all of those things I just talked about can be billed for through our platform.
That's fantastic. Well, we've now been joined. It's quite a procession today. We've got some really great speakers. We've now been joined by Ron O'Donnell. So I'm going to bring him into the studio so that he can introduce himself. And please stick around, Pete, because if you've got time to join in a wider conversation with all my other guests, we'll have about 10 minutes at the end to have a kind of group discussion and debate various ideas. But for the minute, thank you very much for joining me, and I'll speak to you again soon. Thank you. Okay, Ron, you're looking very smart. I feel very scruffy compared to you.
I'm sorry, David.
We've only just come out of one stage of lockdown, and the hairdressers only opened on Monday, and I haven't had a chance to go and have my hair cut yet.
Please take care of that. It's a pleasure to see you again. Thanks for inviting me today. So
that's a pleasure.
I'm Ron O'Donnell, clinical professor and clinical psychologist with Arizona State University. My focus is integrated healthcare, meaning creating a new workforce of clinicians to work with the family doctor, primary care physician, to address the patient's all behavioral health issues, which would include, for chronic medical conditions like diabetes, medication adherence, underlying lifestyle problems like nutrition and physical activity, as well as the comorbid mental health problems and drug and alcohol problems that are so common in primary care patients. So I'm in a program called Doctor of Behavioral Health, where we're training a new workforce of students who represent both behavioral health, counselors, social workers, and the medical field, occupational therapists, nurses, physician assistants, to train them as doctoral providers to be helping physicians with this part of their care. In addition, I'm focused on doing research and consulting in China and Southeast Asia for about 10 years now, working on helping to train physicians and nurses in those countries on some of the same principles. So happy to join you.
That's great for the introduction, Ron. Thank you very much for that. You're in good company, because I think at least two other people have some kind of background in psychology, clinical psychology and behavior analysis. And Noah Falstein, who's the next guest, he's one of the world's experts in gamification. But as well as your role in education, and the work that you do around the world, you are also a practitioner of personal health management. Could you say a little bit about the tools and the technology you use to manage your own health and what particular issues you've come up against?
Sure. Like many professionals, I deal with a very intense workload, a real challenge between family, work-life challenges. So I've always been good about my physical activity. I routinely exercise 6 days a week, pretty intensely, either running, bicycling, swimming. And I'll use, in that case, both an activity tracker, my Apple Watch, and my smartphone app to really keep track of my exercise in terms of duration, intensity, frequency, to really help myself train for doing some non-competitive things like joining in 5 or 10K races or triathlon events over the course of the season. So I routinely use digital health technology to provide myself feedback. I also find, increasing evidence that we should all get up and walk a little bit during the day, right? I am often at my desktop working away, reading articles, working on my email for 6, 7, 8 hours a day or longer. And I now use my Apple Watch to help give me a reminder to please every hour or so get up and take a few minutes of a walk around the house just to get the blood flowing again. That's one level. And on another level, as I, like many of us, go through aging, I've been having to deal with some chronic diseases and conditions and need to use different kind of technology to monitor and address those. So I've been diagnosed with hypertension recently. I'm using a home Bluetooth blood pressure cuff to manage that over time. I've been dealing with sleep apnea for about 25 years now, using a Bluetooth BiPAP machine to manage my sleep apnea. So I'm both a user from a health management prevention point of view and exercise and physical activity, but also with many aging adults dealing with different chronic conditions that come up in spite of best efforts to take care of ourselves.
Yeah, I guess that does raise an interesting point. I mean, I'm fortunate that I don't know that I suffer from any of the conditions that you mentioned. I'm extremely lucky in my life and not having been ill, but I've trod the same road as you, partly out of vanity because I didn't like the way that I looked when I was overweight. You mentioned drug addiction and things like that. One of the observations I made, I know there are some particular problems in the USA with drug addiction, opioids, and the like. Do you think coronavirus could have had a positive effect in making people more aware of the non-drug based therapies that people can use? Digital therapeutics, for example. Do you think that is going to have an impact on drug abuse?
I do, but there's two sides of that coin. On the one hand, we know that the COVID-19 pandemic in the United States and perhaps globally has led to some increased mental health and drug and alcohol problems. You're seeing in the United States and globally increased depression and distress tied to both fear of infection, tied to the severe economic consequences of people having their work hours cut back or losing jobs. So you're seeing increasing global distress because of COVID-19. We have reports in the United States of increased opioid overdoses, increased alcohol use, all tied to the COVID-19 pandemic compared to pre-COVID levels. So on the one hand, COVID-19 has been increasing the prevalence of these kind of problems. On the other hand, you're exactly right that by necessity, we've had behavioral health practitioners, both mental health practitioners and drug and alcohol practitioners, shift to using telehealth routinely for their patients. And that's had two real important positive consequences. On the one hand, people are getting greater access now, and in particular, underserved populations, those who are lower income, minority groups that often have a difficult time traveling to an in-person visit, now seem to have greater access via telehealth to their clinicians online. Anecdotally, I've heard from many of my colleagues who have seen their no-show rates decrease with much better attendance because people don't have to worry about taking 3 buses across town to make an appointment. So you're seeing telehealth increasing access. The jury is still out about comparing in applied research is telehealth as effective as in person, but certainly there's a wealth of evidence showing telehealth can be used as effectively as in person in randomized controlled trials. And last of all, we hope to see that telehealth increases clinicians incorporating other health technologies I already mentioned, whether it's activity trackers, smartphone apps, remote devices and wearables to help bring the patient's home clinical status, whether it's self-report using a PHQ for depression from their home, or sending in their blood glucose through their Bluetooth blood glucose monitor to their clinician, better connecting clinicians and patients by necessity during COVID-19, but for convenience and more efficiency post-COVID-19.
I could see Pete nodding from time to time at things that you're saying there. So I think he concurs with you, and eCare 21 as a platform is a very good initiative for bringing all of this data together. But one question I'd like to ask about that is that when you've got all of this data and all of this monitoring, how do you avoid a situation where the data then becomes an unnecessary alert or a concern for the patient? Is there a danger that we can get people too worried about their health and then consequently place perhaps a bit of an overload on the clinicians?
Well, that's always a challenge. I think we're in a position now to not worry too much about that adverse, side effect of frequent contact. We want to, of course, titrate our contacts. We're not becoming bothersome with text alerts. But on the other hand, certainly in my work in China and Southeast Asia, the percentage of individuals who aren't even aware of their diagnosis of hypertension and type 2 diabetes is very high. And we can't worry about erring on the side of scaring them. They need to be given alerts that they are having serious health problems, even if it's invisible in terms of their immediate feelings of being ill or healthy, right? So we have to err on the side of messaging those individuals, giving more information about education about their condition, give them advice and guidance, whether it's online or via a clinician, about steps to improve their health through nutrition, physical activity, medication adherence. And over time, I think as we get more penetration into the population, we can then worry more about, are we overdoing it for some of the population? And if so, we can titrate that. And last of all, of course, as you're familiar with, David, the increased use of AI to be able to use smart engagement of patients, right? To understand, oh, this patient, based on their data coming in, their blood pressure is good, their blood glucose is good, they're physically active, you don't need to message them right now, compared to a patient that really is having those problems spike in terms of blood pressure, blood glucose, who is showing no increase or satisfactory physical activity. We can use AI to titrate our messaging, so we're saying the right amount of messaging and the right intensity of messaging to the patients based on those technologies.
Well, thanks very much for your observations, Ron. I hope you're going to stay around because we can have a bit of a discussion in the last 10 minutes available to you. Noah's been sat very, very patiently in the background. Noah Falstein is a legend in the industry for his work with Google and his long background in gamification. So I'm going to say bye for the moment for you, Ron, and stay around and we'll bring you in again later on. So Noah, for those few people who have never heard of you, would you like to just say a little bit about yourself and your background?
Sure. I'm very amused by you referring to me that way. My daughter, who is a big Harry Potter fan, said, somebody asked, is your father really famous? And she thought about it for a minute and she said, well, it's kind of like the Harry Potter universe that, most people have no idea who he is or what's going on, but within this very small group, a lot of people know him. So it's certainly not a worldwide fame there, but thank you. And I have been making games for a very long time, started over 40 years ago, and began as a programmer, as almost everybody was back in the late 70s, early 80s, and moved very quickly into design, project management, being a producer. And in the first half of my career, I worked exclusively on the kind of entertainment titles that everybody's familiar with. But gradually over the last 20 years or so, I've gotten more and more interested in what was, first serious games, as you well know. And now in the last few years, it's really come into its own in that the health treatment, diagnosis, training, all these areas are all starting to work with people from the games industry, if not actually games themselves. And I spent 4 years as Google's chief game designer and spent a lot of time with their VR and AR projects there. Left there just about 4 years ago because I really have been so excited about this health aspect that I wanted to get involved with that full time. And so these days I work with a great variety of companies. I've always enjoyed working in a lot of different areas. So working with companies like Achille Interactive that just last year got the first FDA clearance and a CE mark for a video game to treat a condition on its own, specifically pediatric ADHD. So doctors have now been prescribing that here in the US and shortly in Europe and other spots around the world so that people can actually play a game that has been shown to have effectiveness on a similar level as drugs like Adderall or Ritalin, but the most serious side effects that were noted in the studies were occasional headaches and frustration, which I'm very proud to see as relatively benign. but also companies doing pain remediation with games, doing rehabilitation for injuries or stroke recovery, doing wellness applications, often with VR and AR, to reduce anxiety and give people some respite from the stresses of life. And it's been particularly apropos in this last coronavirus year. And companies like LevelX, for example, that are making games that give continuing medical education credits to doctors, but are in fact really fun, entertaining games that are just extremely realistic. They have equal numbers of doctors and medical professionals and game developers on their staff. So quite a wide variety and new things coming up all the time, and a lot of big pharma companies finally getting interested in how to use games to help people's adherence to their health regimens and be more aware of what they can do to increase their health.
Yeah, I guess the situation today is a little bit distorted by coronavirus as far as the pharma industry is concerned, because clearly there is a big opportunity in the life sciences sector and pharma sector for developing vaccines to tackle coronavirus and other kind of conditions, which has maybe taken a little bit of pressure off the pharma industry in terms of their business opportunities for the future. But could you say a bit about the opportunities for pharma and gamification and technology as an alternative to their traditional drug therapies?
Certainly. I mean, earlier you were talking about the opioid epidemic, and one of the, I think, more promising areas where games and in particular virtual reality technology can be very helpful is in helping people with pain management. There have been many studies and many more anecdotal cases of people using games to help people cope with both chronic and acute pain management. And one doctor out here in California, I saw a wonderful presentation a few years ago of a 10-year-old boy who had had a skateboarding accident and had a lot of skin stripped off of one of his arms, a very sad thing. And he needed skin grafts, and I'm happy to say he's since recovered. But while he was being treated, he was in terrible pain, only 10 years old, I think, and needed the maximum amount of opioids just to get his bandages changed. And even then was, screaming and not cooperating. But they luckily had an early VR game that they were able to try. And he was able to put on the headset, and that particular game providentially didn't require any hands to use. You just have to tilt your head to basically do bobsledding down a mountain. And the very first time he used it, he went from the maximum amount that was allowable, that still wasn't good enough, to not needing any drugs at all to be able to get through the bandage changing, and was able to continue that for the rest of his treatment. So again, just one case that I'm talking about there, but that's one of those areas where anything neurological and really pointing at the way that the control of the brain, control of attention in particular, can be used. I think games are particularly effective and may be able to either supplement or replace some pharmaceuticals or other types of treatment.
Yeah, I think you make some very good points there. One of the other aspects that I've noticed about gamification and some of the games and technologies you've described, particularly in the VR. I'll give an example. I think it's a company called XR Health in the USA who've done quite a number of VR applications for things like breathing management, dementia. And a lot of these provide an opportunity to use the capability of games to capture data, which help to understand the state of the condition. I know in gamification that feedback is very important in gamifying, for want of a better word, an environment. But also it's extremely useful for capturing data about medical conditions, is it not?
Absolutely. And people have been talking about wearable devices, and there's a lot of crossover there on the game side, particularly with VR and in the future, I think, with augmented reality as well. In particular, I think one of the interesting things that's just in the early stages now, but we're going to see a lot more of, is that because games can be so demanding in terms of both your mental processes and your physical dexterity, they can be used as a way to catch the very earliest stages of neurological degenerative diseases like Alzheimer's, Parkinson's, various types of dementia. And it's a bit controversial. It's certainly not something you want to do stealthily, but it is certainly possible that with gameplay, even of some of the simple mobile games that people use on their phones all the time, there may be a way to build modules in that can be accessible to companies to plug them in there. And if people choose to turn them on, have them give them sometimes years of advance notice that they may be in the earliest stages of some type of degenerative problem. And catching those very early on can really be very helpful. So I think it's one of the things we'll see quite a bit more of as this progresses.
Yeah, I think, and I can't remember whether it was you I was having the conversation with, and at this point I'll actually bring in Pete and Ron, and if Leon is still around, I can see he's in the room, but he's got his video switched off, so I won't bring him in at this point, but he's welcome to join us. As soon as I see his video, I will add him in. So I think within the collection of people we have in the room at the moment, we've got the brain power to solve a lot of the world's health problems with a different variety of expertise. So could I? Oh, Leon is there now, so I'm going to just bring him into the room. Leon was an earlier guest. He's CEO and founder of a company called Oxytone, have a wearable technologies that capture some of the data that Pete can use in his framework, and Noah can gamify the environment, and Ron can bring forward a new generation of students who can apply all of these techniques. So could I ask you, each of you in turn, probably starting in the order in which you were involved in this program. What's going to be the next big development in digital medicine and digital health? Leon, I'll ask you first. You're muted.
Yeah, very interesting question. So I think it will be something that's implantable, because I think all wearables is just some intermediate stage towards implantable. I think the future of medicine in implantable and non-contact measurements.
I guess that fits in very well with the device that you were talking about, Pete. I know it's a patch that sits on the surface, but do you have any experience of implanted devices?
We're getting those kind of requests from cardiologists right now. They have existing implanted devices that they use. And I think there's also an opportunity. The next level of this also is in workflow design, because the secret sauce really for many of these devices, which creates silos of data that the physician needs to manage across, is to have an ecosystem, as you describe it, a platform that allows you to integrate all of these device data into a clinical workflow that engages all of the parties in real time without overloading on alerts, as Ron mentioned. So you have that titration on alerting, informed by a SaaS or an analytic engine that's giving you the information about what you need to guide the patient, education to inform the patient in real time, so that you offload the clinician by clinically giving them the education based on what you're seeing in the devices. And you don't need a person to do that for the most part. You can give it to them right away if you think it's within the scope of the analytics. And then you apply therapies that are informed and documented in the workflow. And essentially the ecosystem that we built, we view it as a communications vehicle. The real problem we're solving here is communication across the care continuum, and having the real data, real-time data flows combined with the documentation across the settings of care, allow everyone to be informed in the moment of what has just happened prior. So
yeah,
to me, that's the next frontier.
Yeah, I think that's vitally important. But of course, medical data in its own right is really only of value when it can be interpreted properly and acted on. And I guess this is where Noah and Ron come in, is how you translate that data into informing both clinicians and patients on appropriate actions. Noah, I'll just ask you about the process of FDA approval. One observation that I've heard other people make is that when it comes to FDA approval, with drugs and pharmaceutical solutions like vaccines, which go through extensive clinical trials, have been accelerated with COVID-19, once you have a product, it goes to market and it's been validated against the cohort population, that product or that drug doesn't really need to change, except, of course, it needs to be tweaked, as in the case of coronavirus, where you get different variants and mutations. But technology is advancing so quickly nowadays that if you're looking at virtual reality, for example, and augmented reality, there are new devices coming out nearly every other week. How does that affect the kind of clinical validation and approval?
Well, it's a really interesting question. I think that the answer is that we're still in the process of figuring all that out. Yeah, I'm happy to say that I've been a bit surprised at how flexible and forward-thinking the FDA has been. They've really worked hard to acknowledge the issue that you described. And in many ways, I think we're moving into a brand new paradigm, because we do have to have the big randomized controlled trials to test efficacy and safety. But as you say, with software, we're used to changing, the software, you're talking about new hardware coming out. Of course, you get software updates on your, computers and phones constantly and behind the scenes. And that is obviously challenging, because when you're talking about medical treatment, you don't want to, have a bug creep in, that sort of thing. But that said, it also means that instead of having to wait years for an improvement, it can come overnight. And when there are new trials that show that this is effective, it can be downloaded into a new device or updated instantly. So it remains to be seen exactly what's going to happen, finding the balance between speed and safety and efficacy and all these different things together. But happily, around the world, a lot of people are working on solving those problems. And I'm confident, just as with our phones and other technology we use every day, the very ubiquity of it is going to put a lot of speed into the process. So we'll have a good solution for that.
And Ron, looking at education and the students that are coming on stream at the moment, I guess you must have been impacted by coronavirus and doing remote teaching. Has it had much of an effect on your students? Is there more interest in life sciences and the kind of work that you do now? How do you see things going forward?
Well, in my case, I was teaching online before COVID, so there was no real change in my work. But students have always been very engaged. We offer live webinars. I do small student live groups. They feel a sense of being involved in real time with each other and with their faculty. But in terms of, I think, where we're going and what the needs are, I'm not a prognosticator for technology, but I do hope to see simply more dissemination of technologies. And for example, among my peers, psychologists in the United States, I think only a small percentage are recommending digital health tools to their patients routinely in care. That needs to change. We're seeing more and more hospitals and health plans adopt health technologies for their physicians, nurses, et cetera. We're still a long way from population health management with real penetration, right? We're a minority in this call right now. We're all advocates of health technologies. Most of our peers are not there yet. So my role educating students is to make sure all of my courses include digital health technology as an essential component they must incorporate and learn about as they go forward to meet patients, whether it's for medical, behavioral, or lifestyle conditions. They all require apps, wearables, and remote devices.
I read an interesting comment in today's paper in the UK, and it was talking about the fact that medical professionals are not embracing artificial intelligence, and they see artificial intelligence as being a big threat to their profession. And the observation of the paper was, it's not artificial intelligence that's the threat, it's the doctors who are using technology and artificial intelligence will replace the doctors who aren't using technology and artificial intelligence. That's probably a good note to finish on as we come to the end of the program. And I just want to say thank you to all of you. I think it's been the best broadcast yet, certainly the most enjoyable and stress-free from my point of view. So thanks for joining us, Guy, and I hope we'll all keep in touch and find different ways to collaborate in the future. So I'm going to close now, and I'm going to just close with a little sting video which shows what programs are coming up over the next 8 weeks. So thanks very much, guys. Thank you.
Thank you. Nice seeing you.